So I've tried to look at some of the data, but I've tried to also address some of the issues you might have as councillors and or MPs or MLAs, and see where you might feel you can have power to do something about inequalities. There could be an argument to say that actually I'm a councillor, so I've tried to look at maybe some of the oversight or scrutiny issues, the questions you could ask with respect to inequalities when you're dealing with council officers, or if you're working with other groups of stakeholders, or even responding to questions from your populations or communities. So I thought I'd just put up the Making Life Better. They have two main aims. I know Making Life Better is being reviewed, but actually the second main aim of Making Life Better is to reduce inequalities. And of course, the new health minister has announced his focus on reducing inequalities as well. So there's both a policy and political drive to reduce inequalities. What do we mean when we use the term health inequalities? Well, this is the Public Health Agency's current definition that they would prefer people working in this area to use. Health inequalities are the avoidable and unfair differences in health between different groups of people. And I think it's very important to bear in mind those two words. They're avoidable and they are unfair. What do we mean when we say they're avoidable? Well, avoidable health inequalities arise because of the circumstances in which people live, work, and age, and the systems that have been put in place to deal with illness. The systems in themselves may be inequitable. So the conditions in which people live and die are in turn shaped by political and social economic forces. Now, there are various models to look at the different determinants of health. This is the initial model by Dahlgren and Whitehead. I feel it's a bit deficient. Other people come up with other models. So Hugh Barton and Marcus Grant, who are urban planners, came up with this similar model, but it's actually got more determinants of health in it, and it relates to planning in particular. But one of the deficiencies I find in both of these models is that they do not mention the political and fiscal context surrounding all these determinants of health, which actually for you as politicians are really key, because population health is affected by the political and fiscal context, as well as the economic, social, and environmental conditions that people live in, and also the quality, the accessibility, the availability of services for them. And we're not just talking about health and care services, we're also talking about transportation, housing, education. So effectively, the combination, the interaction of these determinants of health have an overall impact on people, communities, whole populations. But this impact is complex, it is cumulative, and it can be intergenerational. And there are, I would say, more intergenerational impacts in Northern Ireland due to the legacy of the Troubles compared with some of the other communities I might work with in other countries, including England. So for me, this is a really important slide because it has, I think, one of the most powerful sentences in it. Inequalities in health arise through inequalities in society. Inequitable distribution of power, well, resources, money, and power. But sometimes it does come down to who has the power to change things when we're talking about inequalities. So as I said, I'd like towards the end of the presentation to focus on how you as politicians, where do you have the power to change something? What kind of questions might you ask about proposals to reduce inequalities, or other proposals that are for the general population that you want to ensure they're not making inequalities worse? So we know the evidence is very strong that people who live in less deprived areas have much better health than people in more deprived areas. The spectrum of these effects across a population is known as the social gradient, but the difference between people living in the most deprived areas and the least deprived areas is known as the social gap. And we need to address both the social gap and the social gradient when we're working on inequalities. In terms of deprivation, the deprivation statistics are pretty old now. They're rooted in 2017. They were published. Quite a lot of the data is 2016. So we're talking nearly a decade ago. If I had a vote in what you might want to advocate for, I think it might be good if the Northern Ireland multiple deprivation measures were updated with the most recent data. That would be one. But if we look at the data we do have at the moment, of the 10 most deprived super output areas in Northern Ireland, 5 are in Belfast: Waterworks 2, Ardoyne 2, New Lodge 2, Woodvale 1 and Ardoyne 3. The other 5 are in Derry City and Strabane. Now, the Public Health Agency wants to make people aware of the 4 key policy areas or domains in which health inequalities can arise. So the first is things like special characteristics, so the protected characteristics that are enshrined in Section 75. You have equity impact assessments around Section 75, and I'm sure you're all very aware of those special characteristics. There are also what's known as inclusion or vulnerable groups. So that might be people experiencing social isolation for whatever reason. And then there are socioeconomic factors or deprivation factors around some of the wider determinants of health: income, housing, and education. And their final area or domain, policy domain, is geography. There's an urban-rural split, but there's very much a place-based approach, which we'll see in some of the data I've extracted for you. The Public Health Agency is currently using this model of what are the causes of health inequalities. So I've tried to group some of the data around this. There are physiological or attributable risks, such as things like high blood pressure, high glucose levels, important in diabetes, people with renal problems, cardiovascular, etc. There are behavioral risks that can lead to these physiological risks. But then there are psychosocial risks that can then lead to the behavioral risks. So if you have low self-esteem, you're isolated, you may drink more than the recommended weekly limits, you may smoke more because you have these psychosocial risks. And then wider determinants of health, the housing need you may have, the level of education you have, your level of income, they may all affect the level of your psychosocial risks, having this knock-on effect to behavioral risks, and then how that appears in people's physiology. So that's their current model. In the Northern Ireland Health Inequalities Report for 2024, for Belfast LGD, we don't have the data at a lower level, but these are the 5 indicators, whereas there is the biggest gap for inequality between the least deprived and the most deprived: drug-related death rate, under 20 teenage birth rate, alcohol-related admissions rate, alcohol-specific death rate, and preventable death rate. And the important thing about the preventable death rate is entirely, as the label suggests, these are deaths we could prevent, and actually we have a large inequality gap in there in Belfast LGD. I've fortunately, not all the data can go down to district electoral area level, but the preventable death rate data do. So if we start at the left-hand side of the graph, we've got Northern Ireland, and I've done kind of like pre-pandemic, and with the preventable death rate, we're crossing over the pandemic. But you can see that for every Belfast jurisdiction I've got on here, Northern Ireland, left-hand most, then Belfast LGD, the high columns that are in the third set of columns, that is Belfast LGD deprived. And then the following columns are alphabetical for each district electoral area. So Balmoral, Black Mountain, Botanic, Castle, Colin, Court, Lisnashara, Old Park, Ormiston and Titanic. And we can see that actually the preventable death rate has actually increased for most of these jurisdictions, I think, apart from Ormiston. That's not good news. But what we can also see is those district electoral areas that have a much higher preventable death rate than others. So Court, Old Park, Black Mountain, and they normally, where there is DEA data for most indicators, it's those three, sometimes Castle, where you've got a high death rate. Titanic wavers somewhat across the indicators. It can be high, it can be low. So instead of looking at it linearly, though, as presented in the Public Health Agency diagram, I think it's more important to see it more like a beehive. You know, different things can combine to give you particular outcomes. So what I was struck by when we did the work on the Belfast profiles before was the education data and the housing data. So I've tried to extract some of that. Actually, I'm quite pleased about the education data. I've split it into free school meal entitlement and non-free school meal entitlement. So we've got the standard indicator we use, attainment of 5 GCSEs, A to C level, including English and maths. And this is for assembly areas, so the 4 assembly areas. I've done it academic year 2019-20. Okay, it crosses over a bit into the pandemic, and then towards the end of the pandemic academic year 22-23. So it goes Belfast East, Belfast North, Belfast South, Belfast West, and then we have free school meal entitlement is the first set of 2 columns, and then for each assembly area, and then it's non-free school meal entitlement. And we can see that there's a gap, an inequality gap between children who are receiving free school meals and children who are not in terms of educational attainment. We know in terms of the evidence, this will affect their entire life course. It will affect the type of employment they get, the type of income they get, what type of housing they will be able to get, what type of environment they will live in. So I feel education is an incredibly important area to focus on if we're looking at trying to tackle inequalities. And actually, this is one of the indicators you would use. What was really heartening, I found, about the most recent data when I downloaded it, if we move to look at Belfast North, which is the 3rd set of columns in, there has been an absolute increase of 10 percentage points for free school meal entitlement children in their attainment. And, you know, you'd look at that and say, okay, what was happening in North over that time? Because North is normally the West. You can see that in 2019, it had the lowest level percentage, 49.3%. Of any of the assembly areas, and now it's become the best over that area. So we can look at North and say, has anything different been done? Have there been projects or activities put in there that we could use in other areas of Belfast? Because none of the other assembly areas has had such an increase, and in fact there's been a slight decrease for free school meal entitlement children in Belfast East. So this is the way we can try and use some of the quantitative data. This is a bit of a soapbox of mine, but there was the Lancet Commission on Dementia. There was the initial one, and then they've reviewed it. But if we look at the top of this diagram, this shows us that we can have a 5% reduction in cases of dementia if we give children better quality education. So children who have less education are more likely to get dementia. So we could actually reduce the number of cases by 5% if we ensured that children got a good education. And the only 2 things we could do that would give us a greater reduction in the number of cases with dementia is looking at hearing loss in midlife and whether people had high levels of cholesterol. So for me, that's quite a good thing, an argument again for improving the education, especially that the quality of education that children with free school and meal entitlement receive. Unfortunately, the news isn't so good in terms of looking at housing need. On the left-hand side, we have housing need in the social renting sector. Belfast LGD is the data on the left-hand side, Northern Ireland on the right. We can see that the waiting list has actually increased in the social renting sector pre-pandemic and post-pandemic. This is 2019-20 is the kind of petrol blue column, and 23-24 is the kind of rust-coloured column. We can also see from that Belfast is about in between, well, almost a quarter of the waiting list for the social renting sector in all of Northern Ireland. I know you've got more population, but it's still a high percentage. Homelessness presenting and acceptances. Presenting has gone down slightly, but so has acceptances. So that's not good. Applicants in housing stress, I've given you on the right-hand side, this is for Belfast. We can see that actually the biggest problem there is small families. If we look at average monthly rent in the private sector, again, Belfast on the left-hand side of the graph, it has gone up pre-pandemic from £708 per month on average to 936. That's quite a hike. That's £200 over essentially 4 years. If we look at housing dwelling completions, if we look at dwelling completions in the social housing sector, and the reason that's a really squished up graph, I apologize, but I was trying to make the two axes read the same, so you can see the relationship between how many social houses are being built and how many private sector ones are being built, so you get some comparison. There haven't been that many dwelling completions in 2019-20. Belfast LGD again is on the left-hand side, but it has dropped in the social housing sector from 150 to 109. But if we look at the private sector, more are being built in the private sector, but even so, there were 569 completed in 2019-20 and only 363 in 23-24. So if we go back to our waiting list data, 12,726 households on the social renting waiting list, but our social housing completions are at 109 and private sector completions are at 363. So it's quite a large amount of housing need. Reflecting on the fact that you have a big inequalities gap in alcohol admissions, alcohol specific admissions. I looked at the drinking prevalence data. This is only at Health and Social Care Trust level. It's actually dropped slightly by 1 percentage point for Belfast HSCT. But the thing to look at that's most important is this right-hand graph. And this shows that for Belfast HSCT, drinking above the recommended weekly limits has gone up 5 percentage points. So that's quite a rise pre-pandemic and post-pandemic. And that could be why you've got a larger inequality gap for that. I looked at the anxiety levels data, and again, this is not a happy look. For Belfast HSCT on the left-hand side, this is very low levels of anxiety. So a drop in the data is a bad sign. So there are now only a third of the population in Belfast HSCT say they have very low levels of anxiety, which means 2/3 of your population have got some level of anxiety. If we look at the prescription rate for mood and anxiety, we can see that that has gone up or stayed the same in Botanic, but it's gone up almost for every Belfast jurisdiction. Northern Ireland is the first two columns, Belfast HSCT and Belfast HSCT deprived as the next two columns, Belfast LGD deprived are column sets 4 and 5. And then after that, we have the data for all the DEAs. So it's gone up from before the pandemic to during the pandemic. If we look at the data, sorry, just for this, labels over the top. Can somebody just tell me which? I can't see which data this is. Oh, I think I know what it is. It's the admissions rate, isn't it, for alcohol? Is
Yes.
that right?
Yeah.
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 Sorry, this meeting is being recorded across the top. Now, we've got a problem with alcohol related admissions because we've got a large inequalities gap. But you think, why is this? Because actually the admissions rate is going down. But if you look at the specific death rate, and we only have this for HSCT level, we don't have any of the DEA or LGD data, we can see that actually Belfast HSCT has gone up and deprived is kind of hanging on in there at the same level. But if you look at admissions have gone down for both deprived and just general population in HSCT. But I think the reason you've got the large inequalities gap, and the reason, although admissions have gone down, death rate has stayed the same in the deprived populations, is because we've got the increase in drinking above the weekly limits of 5 percentage points. That would be my theory, that there are more people drinking above the weekly recommended limit. And so although admissions might be down, the people who do get admitted, and some of whom will die, it's actually because there's more people drinking above the weekly recommended limit, even though the prevalence and admissions have gone down. So when we're looking at what to do about inequalities and inequities, what we have to do, as I said before, we need to close the social gap. That means we need greater intensity of action for people at greatest social, economic, and health disadvantage. So we need to target people who have those greatest levels of disadvantage. However, you can't just do targeting, because if you just do targeting, say we divide our population into quintiles, and you just target the people who are in the bottom quintile, you may be very effective, but what you might do then is mean that quintile 5, actually their health improves, and then their health is better than quintile 4. And what that means is you've just swapped who is the most deprived, and we don't want to do that. So what we also need to do is recognize the level of need in all the quintiles, and then do proportionate action to support people across that spectrum of need. So just because we have deprived populations, say, that's not a good one. But if we go back to prescription rate for mood and anxiety, we don't say, oh, because Botanic, for instance, or Balmoral don't have as high rates, we don't have to provide services for them. Yes, we do, but we provide the services that are proportionate to their need. So we may have to do different things in Court or Black Mountain or Old Park because they have a greater level of need. So proportionate universalism is really important, and we can't just rely on targeting in order to combat inequalities and inequities. Now, you probably are very pro what I'm going to say now, but some of my technical colleagues might not be. I've just shown you a lot of quantitative data. Quantitative data is great, don't get me wrong, but it can only tell you how large the problem is, what the causes are, because we can look at all those indicators. But what we really want to know, and what is the hard nut to crack, is why do these causes exist or persist? And because of that, we need the qualitative data. So that's data from our community, the population group we might be focusing on, like people with disabilities, or the service users we're providing services for. So we need their input. We need good data from them. When we're deciding what should we do about the problem that we've identified for the community or the service users that we're concerned about, then we need to generate hypotheses, decide on what we're going to do. but we also need the community or service user input there for co-design and co-production. When we're asking, did it work? Then we need to go back to our quantitative data. We need to monitor that. But if we're going to say, why did it work? Like, why was there that 10% increase, in kids with free school meal entitlement? That's fantastic in North. Why? How did that happen? We need the narrative from the community or population group, service users, or the people working at the front line, the teachers or whoever who were working with those people. So we need both quantitative and qualitative data when we're trying to tackle inequalities. And for me, it's like the different types of data you can use just create a greater understanding of the problem. It's like each different type of data you have is like another facet on the diamond to make it sparkle more, to give us sort of greater light or information about how we can tackle inequalities. So I just wanted to briefly show you some work we did in White Rock a few years ago now, before the pandemic. It was just a brief piece of work, but essentially White Rock 2, 8th most deprived super output area for employment, 5th most deprived super output area for education, and then White Rock 2, most deprived super output area for health, and White Rock 3 is the 5th most deprived super output area for health. So that's our data from the deprivation index. And the work they were doing in White Rock, the community had 3 working groups, as it were, around what they thought were the 3 biggest problems they had: unemployment, crime and antisocial behaviour, and then use of non-prescription and prescription drugs. And I was just involved for part of that, but I was in discussion with the community, and they had a narrative. They said, these are our 3 big problems, and then they said, these are what we think are the causes of each of the problems. So I offered to do what are known as network diagrams. So what you can see on the screen now is a very busy network diagram. But actually, I took each of their 3 problem areas, as it were, and I made this network diagram for each of the 3 problem areas they had. So I went along to the next meeting and they said, oh, that's great. Can you just bring all 3 together, which is what you're looking at now. Now, I know it looks really busy, and at first you think, well, this isn't going to help me. But how we used this was, especially with service providers working with the community, you can look at where is the busyness in the diagram, which are the nodes, which is what I call them, where there are lots of arrows going to and from them. And if we target that node and say, okay, can we do something about this as an individual organization or as a group of organizations in a partnership, you can then see how effective activity or effective project undertaken there can then flow through the diagram and have an impact through the diagram and all these different factors that will affect people's health and their outcomes. So network diagrams are a very useful way, not just of finding out from the community or your population group, your service users, what they think the problems are. Then we can construct these diagrams and see where we need to take action in order to help reduce any inequalities. So the way in which inequalities arise is complex interaction of many variables over time. And I think those White Rock diagrams really help us see that. But that's one of the reasons why inequalities can persist and worsen. I'm sure you've heard the whole, we must do something about inequalities, for decades. But this is why they can persist and worsen. And this is why inequalities can sometimes seem resistant to intervention. So we need to understand and recognize the complexity and the relative causes and the synergies that need to be identified. And this requires a whole systems approach. Now, I know in Northern Ireland, you're now getting integrated care systems. We've had them for, what is it now, 3-4 years, is it? In England, so you can learn from our mistakes. But in order to do a systems approach, you need the system, a network to support and deliver the objectives of the system, and you need culture change as well. So a system is a set of activities with a common set of objectives and outcomes, and normally you should provide an annual report. Systems can focus either on a symptom or a condition or a group in the population or a particular problem, like we were looking at education. So a network, however, is the set of organizations and individuals who deliver the system objectives. And what's called the pathway is the route that people will follow through the network, or if we're doing community action, that the community follows through the network. So in this diagram, I've tried to show that. I know I'm not brilliant at diagrams, but on the left-hand side, we have the people in different organizations or sectors, community and voluntary, private, public, and our community. And these people come together to form the network on the right-hand side of the diagram. And this network together deliver services for your population or group who have this common need. So what do we need to do to set up systems, then have a common set of values that's agreed by everybody within the system? You need to define the population you're going to be working with. That could be an area population. It could be like a disability group. It could be people who are deprived. You know, it depends what system you're running. What's the level and extent of population needs? So we know how to deliver the services across that spectrum of need. What are the system objectives? And very importantly, which outcomes are meaningful to your population, which are important to population health, and which are important to the system? What are our criteria for monitoring the system objectives? Identifying the services that are already being provided. Are there overlaps? Are there gaps? And then, if possible, identify how much money is being spent on services across the network, so across those organizations, in order to deliver services. The system budget actually is one of the tricky things to do. Now, I was looking at Making Life Better again, as you know, but I just wanted to flag up actually that the shared set of values underpinning action in the pre-review version of Making Life Better, I think these are a jolly good set of values. So I'll leave those. You can all have the slides afterwards, so you can read the detail of them afterwards. But I do think the Making Life Better values are a jolly good set. Engagement and empowerment, social justice, equity and inclusion, collaboration, addressing local need. Those are all things we've been talking about. And I won't go through these slides. They're just to give you an idea, but this is some work I did on end-of-life care in Northeast Essex, where we set up the system for end-of-life care. The problem was that people from deprived areas in Northeast Essex and older people living in care homes, and there are a lot of people in care homes in Northeast Essex because it's a rundown seaside area, highly deprived within output areas in England. And what's happened is all the old hotels have been turned into care homes. So what was happening was a lot of people were dying in hospital who didn't need to be, but a lot of those people were either from a care home or they were from a deprived area. So we set up a system to try and look at that. So this was our population definition. I did the consultation with the families, carers, supporters of people at end of life. Obviously, I didn't interview people at end of life for obvious reasons, but it was very interesting. They came up with these outcomes that were meaningful to them. But it was interesting that near the bottom it says to reduce or avoid unnecessary and futile medical intervention, and near the top to not be given false hope. So if they were dying, then for the service providers to be honest about that. And that really guided our work. We also interviewed frontline staff. This is what they said. You can read that in more detail. But what I want to draw your attention to is that these 10 objectives we developed for this end-of-life care service in Northeast Essex, which was also set up not only to provide better end-of-life care for everybody, but to try and reduce the inequalities we were seeing. These 10 objectives came out of the consultation with the families, carers and supporters of people who were dying, and also the frontline staff, the district nurses, the care assistants, the GPs, etc., who were delivering the service. Now, when you're setting up a system, the person I work for on this says there should always be 4 system objectives that any system should attend to. You will notice that one of these is to reduce inequity. And what happens in general is that we have people with a condition or a problem or an inequality. And what we have on the left-hand side within that group of people, we have people who are receiving the service. And on the right-hand side within the whole group, we have people who would benefit most from the service. And very often when you look at people's need in relation to whether they're receiving a service, whether that might be housing or education or transport or healthcare, what we often find is that you don't get a full overlap between the people who would benefit most and the people actually receiving the service. And this is really key. So what we want to try and do is ensure that the people who would benefit most from the service actually get it. So these are sometimes called hard to reach groups. What I prefer to call them is just people who are not receiving a service that they are in need of. Now, I'm putting up, I know, medically based work, but this was very stark, which is why I'm doing it. It was actually research. It isn't just normal data. So it was very rigorous research, but this is looking at hip and knee joint replacement in the NHS. I know it's 2012 data, but actually it was a really good piece of research. It was done very well. And what this shows is not 100%. This is like a ranking scale, but 100 is good. And if you look at the people who got knee replacements, people from the wealthiest or the least deprived areas were getting all the knee replacements they needed, similarly hip replacements. And if you look at the rust-colored column, those are the people who were from deprived areas or who had low levels of income. You can see that the people who needed the knee and hip replacements are not getting them, whereas the wealthier groups are, because they can advocate, they can pay for it, etc. There are lots of reasons why, but I think that's just a shocking indictment of some of the systems we're running to give people services. Other data we've looked at, there's the similar gap with diabetes care, access to specialists, emergency admissions, cataracts, smoking cessation. This, again, I won't go through it, but this was the list of inequities in service provision that we identified with the service providers and also the families of people dying. So this is where they said there were inequities in provision in the end-of-life care. So going back to what can we do specifically, apart from a general system work, is we have this thing where we've got a policy, strategy, or action plan. We act upon one or more health determinants, we get health outcomes. This is a very simple model from Diedrichsen. But what I want to show you is it's not as complex as the model we developed in White Rock, but this is basically a transportation model, the impacts of transport in terms of things like air pollution, physical activity, community severance, access noise, and road traffic incidents. And I just wanted to show you, say we take action on physical activity, how that moves through the diagram. If we get people to walk more, we reduce depression in adults, we reduce carbon dioxide emissions, making a contribution to net zero. We increase physical activity, we reduce injuries, we reduce air pollution, we reduce osteoporosis, and we increase social capital in our communities. So by just taking one action like that, again, we can flow through that diagram. We can show how taking action on one item in a diagram can help us. That's not to say we should only take action on the one, but it's just about not being daunted when we look at these complex interactions, not being daunted by it, and working with our friends and partners so that different people can take action on all the necessary things. The other thing I wanted to address a bit was actually not just consulting our communities and people in need, really focusing on the people who are not receiving the service and why is it that they're not receiving the service. This is a piece of work that was done by Alcohol Change UK, looking at the relationship between alcohol and belonging to a community. So the model they came up with after they were interviewing groups who were not accessing services to address their alcohol problem. Belonging to a community shapes the experience of alcohol. Alcohol facilitates and reinforces belonging. Belonging can be more important to the people involved than the alcohol, but without alcohol, there can be no belonging, and therefore alcohol shapes the experience of belonging, and so on. The point I'd like to make, the three communities they looked at is South Asian LGBTQ+, and the Polish community. And they all said they did not want to access alcohol services, either because they'd had a previous negative experience or they didn't think it was appropriate. And actually, what they said was, I would want to work with my family or my friends. The South Asian community said we might go to the mosque. So what we have to do is look at, do we then support the people, that these people who don't want to access the services as they're normally provided, do we then support the people who they're going to in order to provide their services? So I've given you the details of that work there. And I promise you, I'm almost at the end. So in terms of looking at this complexity of interaction that give us these health outcomes and the inequalities within the outcomes, we need recognition and commitment from all sectors of society. It needs to be multidisciplinary, multi-agency, partnership working, not only horizontal, which is what we tend to think about, but vertical. We need co-creation with the community or population. If we're running a managed network to deliver services within a system, we have to have defined and agreed roles and responsibilities. We need to explore the potential to share or pool resources. We need to identify different opportunities to intervene throughout people's life course, like we saw in that dementia diagram. We need to work in a variety of settings to facilitate this. We need to integrate an assets-based approach to the design and the implementation of our interventions, especially when working with the community. And we also need to identify the value of interventions and channel resources into higher value interventions. So there are some suggestions from the Public Health Agency. And what I just wanted to reflect on in terms of your roles as politicians, you know, sometimes people say to me, oh, just tell me 3 things I can do. So if somebody's presenting you with a proposal that they might like to implement, either for the general population or for people who are experiencing inequalities, we have a tool that I worked on with Belfast Healthy Cities and service providers, health equity tool. But what we did was we broke down the elements of services in terms of components of equity. So is a service available? Is it accessible? What quality is it? Is it a good quality? Is it acceptable to the people who want to use it? Is it affordable? So there you might look at transport and the affordability of your transport service. Is it safe? Very importantly, is it responsive to people's needs? So as a politician, you can say, well, is it available to all the population, but is it actually addressing people who aren't accessing the services at the moment? And if not, why not? And also the other one that I think could be good for politicians to ask is, okay, it might address existing inequalities, but will any new inequalities be introduced with this proposal? So those were some suggestions for sort of oversight and scrutiny you might have when you're working as politicians to devise proposals or interventions to reduce inequalities. So thank you very much for your attention. And I've put Caroline's email on there if you've got any questions subsequently.